In order to perform a high-quality gastroscopic examination, first and foremost, the positioning of the patient is very important, as displayed on this image. When the endoscopist examine their equipment, they need to check all the dials and locks are released and the suction and airflow button is working. On intubation, you are going over the tongue and behind the cricoarytenoid cartilage and identify the upper esophageal sphincter and negotiate to intubate the upper esophageal sphincter into the upper esophagus. Then a gradual and slow withdrawal would allow you to examine the esophageal mucosa on insertion as well. If there is any residual mucus or else debris is found, you could wash with simethicone mixed with water and suction could be applied, followed by air inflation to expand the esophageal mucosa for clear visualization. On entering gastroesophageal junction, it is important to note the length of gastroesophageal junction from incisor teeth. And it is important to document the distance as it has got clinical and anatomical relevance. On examination of the stomach is the most important part of the gastroscopy examination. If there is any residual fluid that needs to be suctioned and all the walls needs to be sprayed with simethicone infused water to get adequate mucosal views. And special consideration needs to be given to examine the gastric antral region carefully. Most of the pathologies occur in the gastric antral region, followed by intubation of duodenum, then careful examination of duodenal bulb, and first part and second part of the duodenum, as well as the duodenal fold and villus pattern of second part of mucosa. If needed, suction and washing to be applied. For example, in this particular case, as this patient was presented with iron deficiency anemia, we have taken duodenal biopsies, 4 from the second part of the duodenum and 1 from the duodenal bulb. And a careful and a controlled withdrawal is very important to examine the mucosal lining of the upper GI tract. Any residual fluid needs to be suctioned and the mucosa of duodenum, stomach and esophagus is carefully examined. Careful examination of incisura, gastric body, gastric lesser curve and greater curve needs to be carefully examined. We would normally perform a J maneuver or else retroflexion on withdrawal, as it may cause slight discomfort for the patient who is undergoing the procedure. So it is important to have a very good and thorough examination of gastric cardia and gastric fundus, as most of the pathologies could be located in these locations. Once again, we would like to reiterate, if there is any residual fluid needs to be suctioned and gastric fundal and cardia area is thoroughly examined. Recently, British Society of Gastroenterology published a positional statement of her quality standard in upper gastrointestinal endoscopy. And it is important that we need to take 8 pictures and photo documented for quality assurance purposes. The sites that we need to take pictures are upper esophagus, gastroesophageal junction, fundus on retroflexion, gastric body, incisura on retroflexion, gastric antrum, duodenal bulb, and distal duodenum. It is important to have a slow, gradual, and a systematic withdrawal of the scope in the esophagus to examine upper, middle, and lower esophagus thoroughly. If we do a rapid withdrawal, a significant pathology just underneath the upper esophageal sphincter, such as cervical inlet patch, which was found on this case, could be missed. Therefore, it is very important to apply a gradual and a systematic withdrawal on esophageal examination.